The next, I would like to invite Dr. Raj Pandian. The next for the next talk, topic is RPC and IPAA for ulcerative colitis.
Good afternoon, everybody. First of all, thank the scientific committee for giving me this opportunity. So next 12 minutes, I am just going to show two videos. It is a case capsule. The topic is restorative proctocolectomy with IPAA, in ileal pouch and anastomosis for ulcerative colitis. So it's a case of acute severe ulcerative colitis with a toxic megacolon. So first I did a total colectomy, then followed by, after 6 months, then we did a restorative proctectomy with the IPAA. Then after 6 weeks, we did the ileostomy reversal, and patient is doing fine. So this is the fellow who is a known case of ulcerative colitis on irregular treatment for nearly a year. He came with acute exacerbation, and he has been treated with the medical colleagues for more than 2 weeks. And he was in ICU, and he has developed all sort of complications with the dyslipidemia, metabolic alkalosis, bone marrow suppression, with severe cutaneous vasculitis. And this was his colonoscopy finding with extensive necrosis and ulceration. And suddenly he developed obstipation with the X-ray shows features of toxic megacolon. This is the CT scan. It was tachycardia, so planned for a total colectomy. And this is the theater setup. I am not going, this is the port patient for total colectomy or TPC as well. This is the team setup. So this is the picture which shows, so on table, this is the picture of a toxic megacolon, how it looks laparoscopically. This is before decompression, this is after decompression. So on table, after keeping the ports, so I asked the medical colleague to do a colonoscopy and the decompression, because without decompression, if it touch, it will perforate. So if you have a perforation, the mortality will go to 40%. If you operate in non-perforated, it will be around 8%. So theater setup, port position I have shown. Procedure I will be just talking while I am showing the video. So this is the picture as I put the scope inside. You can see extensive dilated transverse colon with about to perforate like a ischemic colon, you can see. So after it getting decompressed, you can see how tethered it is, like a friable. So without touching the transverse colon, we have to do the total colectomy. So the inflamed mesocolon will be there. So I am just dissecting the left colon at the rectosigmoid junction. So I am just going to control the superior rectal vessel. I am not going to the IMA fully. But colonoscopy wise, the rectal mucosa was normal this time. So I thought, okay, later we can do a ileorectal anastomosis while I was doing the total colectomy as a emergency procedure or like an urgent procedure. Just I am dividing the superior rectal vessel to have a division at the rectosigmoid junction, keeping the rectum behind. So after dividing at the rectosigmoid junction, through a green stapler, then the dissection carried along with the mesocolon. These are some of the sigmoid vessels. Then this is the left colic and IMV. The left colon is mobilized, there is splenic flexure mobilization. So this is the IMV. So the dissection should be careful because of the inflammation, acute inflammation, there will be a little bit bloody. All the inflamed mesocolon will be there. But you have to dissect the DJ flexor nicely. And coming to this is the left colon has been mobilized, splenic flexor has been mobilized. Now coming to the right colon. So routine like IRITA technique, initial retrocolic endoscopic technique. So if you are in correct plane, even in inflamed IBD patients, you may not have much of bleeding, but you expect more inflammation of the colon. but our aim is to do at the IMA at its origin, ileocolic artery at its origin, because later if we require a pouch formation, then the pouch has to reach the anal canal. So like a routine right hemicolectomy, I am gone to the ileocolic artery at its origin and I am dividing, thinking that later he will may end up in pouch. So always while doing the emergency colectomy as well, you have to do the ileocolic artery at its origin so that later it will be easy. So now the duodenum has been separated from the mesocolon. So just a right colic vessel. Usually I will be taking the middle colic right and left branch, but in this case thinking that there may be more bleeding while dissecting the mesocolon, I thought okay, we will come from above. There are two ways of controlling the middle colic. You can come from above. So now the gauze piece which I kept over the duodenum will help while doing the lesser sac approach while the hepatic flexor mobilization. So now later at the end we will be controlling the middle colic vessel. The hepatic flexor has been mobilized. Now the middle colic vessel along with the gastrocolic trunk. So now the whole colon has been mobilized. The thing is, while handling, now only we are dividing the middle colic vessel. So judiciously you have to use the clip and use ligashore so that there will not be much bleeding, because the patient is already having a low albumin and thrombocytopenia. So there will be more ooze and inflammation will be there while handling this colon. You should be careful. You should not perforate the colon. That is the tricky while the whole colon has been mobilized and be lying, and most of the time it can go in between the mesentery, small bowel mesentery. So while removing you should be careful. So you should not tear the colon. So through the end ileostomy site, the specimen was out and end ileostomy done. And this patient was having extensive cutaneous vasculature. Even if just for handling the skin, there was you can see it was petechial hemorrhages was just I was handled while putting only the port. That because of cutaneous vasculitis. So successfully we could do, and this was the specimen of the toxic myocardial acute severe ulcerative colitis. So post-operatively patient was kept in ICU for 3 days, symptomatically improved and discharged on 9th post-operative day, and patient was on regular follow-up with medication, and he was following the remaining rectum was also medical treatment. His general condition improved, and he was weighing 42 on the day of surgery, and now he became 81 kg. And follow sigmoidoscopy shows severe ulcerative colitis of the remaining rectum. So we can't do, we can't keep the rectum behind. So I planned for a restorative proctectomy with IPAA. So after 6 months, this was the patient. You can compare how he was looking before and after 6 months. He has put on weight 81 and he was like a obese, and this is the end ileostomy, and this is what it looks. You can see it was like a virgin abdomen. So because we have done a laparoscopic, there was no adhesion at all. If the same patient, if you hadn't opened, you couldn't see so severe. So there is a retroperitoneal adhesion has to be released, because we have to bring the ileal pouch to the anal. So all the adhesions of the small bowel mesentery has to be removed. So I am going in a TME plane to remove the rectum as routinely, because I don't want to keep the mesorectum, because inflamed later it can affect the pouch function. So like a TME plane, I am just going into the mesorectum. From medial to lateral I have gone. Whatever the remaining clips you can see last we applied in the superior rectal artery, I am just going beyond and removing, but I am not going up to the IMA since it is not a malignant case. So I am left behind at the origin of the superior rectal vessel. So after ligating, we are going to the TME plane to remove the rectum. Since the remaining rectum also have severe inflammation with the severe ulcerative colitis, you will have an inflamed mesorectum. But still, if you are in a correct plane, you will not have much bleeding. And I am very careful to maintain to preserve the adenovillus fascia because he is very young. So don't want to have any nerve injury. So dissected up to the anorectal junction, up to the pelvic floor. First posteriorly, then laterally, then coming to the anterior. So here we have entered the anal canal. We have gone to the pelvic floor. You can see the adenovillus fascia covering the prostate. So now fully mobilized distal rectum. I am using a vascular cam to before dividing to make sure at least we have to preserve the anal transit zone. So dividing with the endo-GA stapler at the anorectal junction. The specimen was looking big, little bit big, so I don't want to disrupt through the ileostomy side. So you can see the twisted distal end ileostomy. He was having a little bit of parastomal hernia. Anyway, I have to again keep a diverse ileostomy, so I don't want to make a bigger incision on the ileostomy. So I make a suprapubic separate incision to remove the rectum because it was bulky. After removing that, doing a ileal pouch through the ileostomy site is more challenging because the main thing, the ileal loop, that ileal pouch has to reach. So you want to preserve maximum distal ileum because while removing you should not waste the ileum. So I am just taking a 15 centimeter loop of the distal ileum to make the pouch using endo-GA stapler. I use white stapler 3, that is 60 mm white. Usually 3 I will take, so it will come a 15 centimeter pouch. Usually 12 to 15 centimeter pouch is enough. Usually aim to have a 15 centimeter. So distal part of through the distal I am taking the anvil after making the 3 endo-GA stapler, white stapler pouch. J pouch, standard J pouch always make. Fixing the anvil. Just last 1 minute. Excess ileum is removed, sutured, kept inside. So pouch anal anastomosis. Closed, fixed and closed. So while closing, you should make sure there should not be any twist in the pouch. Downward is clear. And again we have kept DT and diverse ileostomy we have kept around 40 centimeter from the pouch. There should not be any tension while keeping the ileostomy. So this was the comparative picture before and after. So you can see the improvement and you have done a good job. So his ileostomy was reversed after 6 weeks and he is on regular follow-up now 6 months and doing fine, and he is passing motion like 4 to 5 times per day and he is sexually active. That was very good news. Okay. So this was written in the accuracy textbook. Thank you. Any question?
Fantastic demonstration, Raj. It's open for discussion to the floor.
Two questions basically. One is, when did you close the final ileostomy?
Sorry?
When did you close the final ileostomy?
Why did you?
When?
6 weeks.
6 weeks.
After 6 weeks
after
of this, yeah.
And secondly, do you get to see pouchitis, from the ileal pouch?
No, so far no pouchitis.
Right.
He is in follow-up now only 6 months.
Okay.
Any other question?
Any take for 2-stage procedure? what are the cases in which you do two-stage procedure?
Yeah, that I didn't show actually. This is why I show this is particularly because this patient developed toxic megacolon, so we can't do a single stage, two-stage procedure. But we routinely do other cases like urgent in severe ulcerative colitis. Directly we do a total proctorectomy with ileal pouch anastomosis with a diversion, and after 2 months the ileostomy will be reversed. Yes, that was routine. But this is with a toxic colon, patient may not, and even initially the rectal mucosa was normal, so we will be in a dilemma. So this is like emergency. Patient was in ICU, is all sort of complications. You can't do a direct pouch anastomosis. You have to do total colonotomy, then let him improve. That we can show. That was so he has improved like 40 kg is regained.
Okay. Raj, just one question. After the first operation, when the patient was having proctitis in the rectal
He was not
stump,
having proctitis.
ulcerative colitis
Yes,
in the
severe
rectal
ulcerative
stump,
colitis.
was he kept on steroid?
Yes, yes. See, all sort of all the medical treatment has been given and it was failed, and he was deteriorating.
Okay.
So all steroids was given, and even he was planning to start a biological, but patient was not affordable.
Okay. And after the ileal anal pouch anastomosis, was the patient kept on steroid for some time?
No steroid. After that, he was only in mesacol only.
Okay.
No steroid after that.
Okay, thanks a lot, Raj. Thanks a lot for a wonderful presentation. Thank you.
Thank you.